Welcome to McMaster Minds, a podcast brought to you by McMaster University's undergraduate psychiatry program. This podcast will explore psychiatry training and the path to getting there through honest conversations with residents and staff. We hope this gives you a sense about the life of a psychiatry resident and staff psychiatrist, and that it helps you make the decision about whether psychiatry, and hopefully McMaster, is right for you.
Joining us today is Dr. Charlebois, a staff psychiatrist at St. Joe's. Dr. Charlebois, thank you so much for being here today. Could we get started with a quick introduction?
Yeah, so I'm Dr. Charlebois. I'm a staff psychiatrist at St. Joe's. I'm the head of service for the psychiatry emergency services. I also represent a third of the hospital's consult liaison psychiatry team. I also have an outpatient practice and a few other kind of smaller clinics and activities that I'm involved with. So I'm kind of all over the place in terms of the different areas of acute psychiatry.
We'll be talking today about stigma and stereotypes in psychiatry. And to that point, psychiatrists themselves are often the subject of stereotypes, sometimes jokingly and sometimes seriously. What stereotypes do you feel like psychiatrists are subject to? And have you ever encountered such stereotypes yourself?
So it's an interesting question. Because there's stereotypes, I think, about every specialty. And probably some amount of them are rooted in some amount of truth. I remember disproportionately worrying about this when I was a medical student. I was worried, about being stereotyped, and I was worried about the degree to which the stereotype might be based on any sort of truth. The context of my experience is mostly in the acute system, so I mostly work in the hospital. I do have an outpatient practice as well, but I'm in the hospital a lot of the time, and I actually haven't experienced very much stigmatization in that context. After about 10 years of being in psychiatry, I think there's only one instance, which was actually interestingly very recently, that stands out as being kind of stigmatized for not being a real doctor is kind of the main one that people get wrong. I think the stereotypes of every specialty are vastly overdone in medical trainees. And when you sort of enter the workplace, a lot of that really fades away. I think the most salient one is like, you're not a real doctor. Part of this is in good faith. People don't understand the difference between psychologists and psychiatrists. And most people who get that wrong, you just advise them like, no, a psychiatrist is the one that went to medical school. And then they're like, oh, so there's that stereotype. I was trying to think about other potential stereotypes, and I consulted a few of the residents and a few of my colleagues. I think another one of the stereotypes, interestingly, is stereotyped to both extremes of the spectrum. One stereotype is like, all we do is therapy, there's no medicine involved. We're just talking about people's childhoods the whole time. And then the other stereotype is all we do is push medicine, and we don't do any therapy, and we just prescribe antidepressants and antipsychotics, and that's it. And you don't talk to them about your feelings. Go get a therapist or a psychologist for that. Interestingly, like, can they both be true? Like, do they cancel each other out? So that one comes up. I think there's also kind of a stereotype about the job of psychiatry. It's an incredibly heterogeneous sort of practice situation. And when I Googled and I chat GPT'd like, what is the average salary of a psychiatrist? And the number that it came up with was like quite surprisingly like low to me. And I know there's kind of a stereotype like psychiatry is underpaid, and arguably if they wanted to pay me more, I wouldn't argue against it. But I think you don't often see it pitched as it can be one of the best paying specialties in different contexts. The other stereotype that I've seen more in trainees and more in them facing it when they're choosing their specialty is sort of a projection of usually like pre-existing family members culturally influenced stigma against psychiatry. You'll tell your family like, I'm going to go into psychiatry, and like your aunt at the dinner table is like, those people are all violent, those patients, or like you're going to catch schizophrenia or something like that. And it's sort of getting subsumed into like a general sort of cultural stereotype about mental illness. That's less common, I think, lately, but it is still something that I see learners contending with. It's not so much from your peers; it's usually from like family members and stuff like that.
Absolutely. I really appreciate that response. It reflects that there's quite a large variety in the different things we can encounter, but also that the preconceptions learners have seem to get much more qualified when we actually start entering training in the workplace itself. One stereotype that you did mention that I want to ask a bit more about was that idea that, psychiatrists are not real doctors or don't practice, real medicine. And to that point, I'm curious, like, what are your thoughts as to why that stereotype still persists?
Part of it, I think, is conflation of psychology and psychiatry. People see it on TV, and again, it's usually um, just some Freudian style, tell me about your mother stuff. And I think we are probably accountable for some of it as a specialty. Like in psychiatry, I do rarely see colleagues who kind of jettison as much general medical practice as they can. And I think, that does a disservice to their patients and to the specialty and even to their own careers, I think. So I think there are instances out there of psychiatrists who are very actively trying to avoid things that are outside of their specialty. That being said, you'll also see, like the orthopedic surgeon who subspecializes in ankles is only doing ankles. Like they're not taking consults for neck and spine injuries and everything else. They don't get stereotyped as like the ankle guy. Um, so there's probably some amount of unfairness that it's happening with psychiatry. I also think in medicine, when we do things so many times, and a lot of it is kind of going on in the background, that we don't realize all of the medicine that we're practicing while we're practicing it. So when I'm seeing a patient who's complaining about something simple like, um, a panic attack, I'm not really in touch with the idea that I'm well aware of how to clinically and biomedically work up chest pain with cardiac features, the sensitivity and specificity of troponins, rarer conditions like pheochromocytomas. Um, I'm not aware that that stuff is running in the background while I'm asking about a panic attack. And that as soon as, a red flag feature pops up, like that comes into play, but it doesn't occur to me that I'm touching cardiology there. We take it for granted that we actually know, hundreds of medication interactions and which CYP enzymes that deals with and the half-life and which organ eliminates it and how does that organ function. Like in this patient, how's their renal function and their hepatic function. We're not aware that all that stuff is like running in the background, which is like bread and butter medicine. But we kind of, I think, take it for granted. And you don't really see it until not so much in Canada, but in other places where they let non-physicians start prescribing, and then you say, oh my God, how could you do that? We don't realize how much medicine we're actually practicing.
I am also curious, like, to your earlier point about how, different subspecialists also, focus on one area and, may or may not face that same degree of stereotype is like, how do you find like the differences in psychiatry training versus training to other specialities?
The first year of psych residency in Canada is fairly focused on like multiple different specialties. You're doing multiple blocks of internal medicine on CTU. You're usually doing multiple blocks of some version of neurology, so like adult and pediatric neurology in our program. You're doing usually some sort of like addictions medicine or something in that vicinity, which overlaps heavily with um, mental health, but there's a lot of separate sort of internal medicine and pharmacology that happens there. There's a lot of overlap with other medical specialties. Throughout the 5 years, you're regularly in our emergency department, literally in the same emergency department as all of the other specialties, and participating in the sort of assessment and evaluation and medical clearance of patients, which involves a lot of medical knowledge in order to appropriately and safely sort of accept and disposition patients and rule out anything and admit them to hospital safely. You're also doing usually some sort of a consult liaison psychiatry rotation as a resident, which overlaps a lot with a lot of other medical specialties. Even when you're on your sort of like general inpatient rotation, which is like a 3 to 6 month rotation in PGY2, you're dealing with all of the ward call stuff. So, when your patient starts vomiting or has diarrhea or a fever or hypotension, or they fall and did they hit their head or they have a wound, you're the first one who's assessing and working that up and determining what to do next and whether or not to transfer. And you not only need to know about it for your direct assessment, but also when you're advocating for that patient with other medical specialties, you have to know like what are they going to take seriously and what are they interested in and what are they going to want you to have done. So that overlaps quite a bit.
Next question I'd like to ask is to come back to the discussion we were having earlier about the different types of stigmas and misconceptions that do exist within psychiatry, either projected onto psychiatry. To all those points, I'm curious, what is your view on what we can do to start addressing some of those misconceptions?
I think the thing that most causes people to update their models of understanding is experience. And so long as people are, as students and trainees are experiencing, psychiatric training, I think you can't help but sort of update your model when you're on your psych rotation and you're worried that your antidepressant is lowering the patient's sodium, like SiADH, and your staff asks you, like, what are the first 4 labs we would run to work up hyponatremia? And you're like, oh crap, like I didn't know this was something that I had to know for psychiatry. And then you immediately realize like there's a lot of medical implications to this. And I think that updates our sort of models more powerfully than anything else.
And I'm curious also what you believe for the role of public education and media and portrayal playing in that addressing of misconceptions.
My knee-jerk thought is that it's a losing battle because there's such powerful, widespread sources of misinformation that you kind of just have to be the change that you want to see in the world and hope that that has an impact. But that's not just for psychiatry, that's for every medical specialty. We've got like the nephrologist, Dr. House, operating on patients and taking his own pathology slides and all that other stuff. Like there's just like big signals of inaccuracy for every, I think, medical specialty. There's also increasingly a subset of very active social media influences. I think it's a lot easier to spread misinformation than to correct misinformation. So you can set a bunch of misinformation fires, and each of them takes a lot of time to put out. Again, like be the change that we want to see in the world, and we practice solid like evidence-based medicine. We integrate as much of our medical expertise as we can to helping patients. I think that'll do the most lifting in terms of the perception and stigma around psychiatry.
To close up the discussion here and wrap up a bit, I am curious if you've found stigma towards psychiatry as a career something that ever made you question your path, and if that were the case, what things might have helped you stay committed to psychiatry?
When I was a clerk, it was like a crisis for me. Not the stigma itself, but the feeling like I wasn't worried like everybody's going to make fun of me or something. But it was, that idea that like you're not practicing medicine. And I was somebody who actually very much enjoyed all of the other rotations and clerkship. And I really felt like I'm giving something up. And I'm giving up medicine if I go into psychiatry. And of course, I bumped into a geriatric psychiatrist. I did a rotation and elective with them in clerkship. And like every patient that we saw had like 5 medical comorbidities and like, 15 medications that we had to know all of the implications of, and a bunch of neuropsychiatric issues. And it was like, an overwhelming amount of medicine. And there's a version of that for multiple different corners of psychiatry. So having that experience really sort of assuaged my concerns that I would be giving up anything any more than choosing any other specialty. I won't pick on anybody, but you don't see person from specialty A like doing the workup of specialty B. You don't see a lot of stethoscopes on any specialties in the hospital. So I think, yeah, that helped me to sort of like calibrate my concerns. Going back to, battling stigma, I think like just experience, I could only come up with one example of kind of being treated differently for the label of psychiatrist. And that was a really small, like it was a outpatient lab that wouldn't let me order an ultrasound on somebody. They said an actual doctor has to order it. Um, but everywhere else, it's actually been quite the opposite. Like I have colleagues in other specialties that are approaching me, it's a very humbling and sort of like honoring experience that they're approaching, asking questions about their patients and about their loved ones, and all kinds of other stuff. I'm frequently being approached, for my expertise, which overlaps with a lot of medical issues. So it's actually, in my experience, quite the opposite. Like people very much appreciate somebody who has medical knowledge in mental health.
Really powerful to hear. And to that point, I want to ask, like, what advice would you also have for medical students who might be thinking about psychiatry, but who are more worried about the stigma and receiving judgment from others? And what are some things that you've also found that make the field rewarding despite some of the challenges that people can face?
In terms of the stigma, whatever we might be worried that we might experience, our patients are definitely going to experience that times several orders of magnitude. And so it ends up being, an unfortunate but deeply important opportunity to advocate for our patients. There's a lot of examples that we could talk about in terms of the impact of like stigma of medical illness in the context of psychiatric illness uh, outside of the hospital, with social issues that are disproportionately affect our patients inside the hospital when they present with potentially medical complaints and they're not adequately worked up. Being somebody who can have medical knowledge and mental health knowledge to help, like, a human being navigate that is incredibly important. It's rewarding to be able to help somebody. It's unfortunate that you have to, but there's a lot of instances where nobody else is there to do that. So, I'd say that's pretty motivating. The second half of the question, obviously it's the best specialty. It's such an incredibly rewarding career for so many different reasons. It's hard to, we would go long if I talked about all of them. I think the biggest thing, the biggest piece of advice that I would, give to learners would be to, find somebody who is kind of practicing in a way that you think resonates with how you would want to practice. And you'll see for yourself that like there's incredible opportunities to participate in every element of the biopsychosocial elements of human existence. And in a way, you get to incorporate almost like more, whereas the stigma might be that you're only doing like a sliver. Like if you're using the biopsychosocial model that is sort of like the pillar of psychiatric medicine, you're actually incorporating even more. You're incorporating all of medicine and the entirety of your patient's, physiology and genetics and pharmacology and everything else. And then you're also adding to that a bunch of other stuff, which is not heavily emphasized in the rest of medicine. And you can argue it's an even more comprehensive approach to well-being, which is awesome.
Yeah, absolutely. It really is awesome. Before we finish up today, Dr. Charlebois, are there any other final thoughts you'd like to leave with our listeners regarding tackling stigma or promoting a better understanding of psychiatry?
In terms of the stigma that you might face going into psychiatry, as like the provider, um, I wouldn't worry about that in the slightest. I think it's very much, over determined in these sort of like pre-residency stages, and you will likely be pleasantly overwhelmed by all of the medicine that you're going to be responsible for. If you're going into psychiatry, I'm going to miss all my medicine halfway through PGY1, you'll be so overwhelmed with all the different medicine areas that you're going to be responsible for, which will be a great problem to have for this particular individual. So I wouldn't worry about that. And then, yeah, I would just recommend when you're in your other your non-psychiatry rotations and those blocks and everything like that, you know, getting as much as you can out of them, because even though you're not going to be, in an obstetrician gynecologist, your patients are going to disproportionately not be able to access OB-GYN care, and they're going to have problems related to, endocrinological function or things like that, that you're going to be the only one there for them for this, and at least knowing where to start and where to direct them, if not the times when you're actually going to intervene there, is going to be really important to them. And that, for all of the other sort of blocks or specialties, is going to be the case. So I would recommend, trying to be on top of everything that you can, because it ends up being really important for your patients. It's such a great career. It's such a great specialty. And I can confidently say, I almost feel bad to debate the premise of the stigma piece. The stigma that we face is very minimal. There's a ton of appreciation that we get from our colleagues. The stigma that our patients face is terrible, but we're signed up to try to help them through that. So that's just another reason to do it.
Thank you so much for your time today and being with us, Dr. Shalbra. Food for thought on how to deal with all of that. Thank you for your time today.
Thanks for having me. It's been a pleasure.